This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2017, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Taking Charge, the RT's Role in Tracheostomy Management. Upon completion of this AARC webcast, participants will be able to identify indications for tracheostomy in the adult and pediatric populations, discuss selection criteria for tracheostomy types based on patient need, clinical indication, and availability, identify factors involved in tracheostomy management, discuss challenges encountered by patients, caregivers, and respiratory therapists in the home, acute care setting, and long-term care setting, and discuss the respiratory therapist's role in the management of tracheostomies. I am pleased to welcome Ms. Julia Lawrence and Mr. Ankeet Patel. Ms. Lawrence is a registered respiratory therapist and neonatal pediatric specialist. She is a clinical simulation specialist at Texas Children's Hospital in Houston, Texas. Mr. Patel is a registered respiratory therapist and adult critical care specialist. He is the clinical manager in the adult care section of the Department of Cardiopulmonary Sciences at Rush University Medical Center in Chicago, Illinois. Neither Ms. Lawrence nor Mr. Patel have relationships to disclose. I disclose I am a paid employee of the AARC. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Ankeet and Julia, welcome to the program.
Thank you, Shauna. Our tracheostomy is a big part of a procedure that's for the adult section and for the pediatric section. So me and Julia would like to take this time and introduce tracheostomy as a whole to our respiratory therapists. Some of the indications for adult tracheostomy include prolonged intubation, upper airway obstruction, unable to insert an endotracheal tube, which we call a difficult airway, and airway protection. Some of the reasons for upper airway obstruction could be due to vocal cord paralysis. Difficult airway we define as upper airway trauma, if there's any maxillofacial trauma. Airway protection generally is for patients that have neurological injury or neurological disease. Some of the benefits of tracheostomy is improved patient comfort, improved management of secretions, decreased use of sedation, ability to communicate, unlike when you have an ET tube in place, helps facilitate ventilator weaning, also decreases time on ventilator and length of stay, possibly, as we will see in future slides. Improves ability to mobilize patients. It's one of the key reasons why tracheostomy could be done is patients are able to participate more in PT and OT. Weaning can be more aggressive because if patient fails to be off the ventilator, it's easier to put him back on a ventilator than when having an ET tube. The airway resistance is also less, which also facilitates weaning a lot quicker than an ET endotracheal tube. So when is the right time to perform a tracheostomy? Several studies have been done to discuss late versus early tracheostomy. I'll discuss some studies here that I've looked up. The first couple that I looked up were observational studies. So mind you that these are not randomized controlled trials. These are just retrospective data that were looked on. One of the studies that I looked up reported early trach resulted in liberation from mechanical ventilation earlier and also decrease in length of stay and hospital length of stay. Another study reported that early liberation from mechanical ventilation had no impact on length of stay and hospital stay and also had no impact on mortality. So some of the things that other studies look for is ICU length of stay, hospital length of stay, mortality. VAP rates is another big one that they try to discuss. Both of the studies that I mentioned here said there were shorter time on mechanical ventilation, but the ICU and hospital length of stay were about the same. Another study that I looked up did a meta-analysis. They did 7 trials were analyzed. All of these were randomized controlled trials. There was about 1,044 patients in these 7 trials that were analyzed. The study concluded that early tracheostomy did not significantly reduce short-term mortality, long-term mortality, incidence of VAP, duration of mechanical ventilation, the use of sedation, and shorter stay in ICU or hospital stay. So you can see there's other similar meta-analysis done that had similar results that are not discussed here, but there are other results as well. Next study is the Trackman study. It's one of the largest multi-center studies done in the UK. It was done from 2004 to 2011. It is 70 adult general and 2 CV ICU were included. There's about 909 subjects that were included in the study. The primary outcome that they looked at was 30-day mortality and 2-year mortality. And you can see here from the Kaplan-Meier curve that pretty much the early and late tracheostomy are pretty much the same results. The mortality is pretty much the same, so you can see there's no difference in that. There was no assessment of VAP in this protocol, which was kind of a limitation, but did also mention that there was no decrease in ICU length of stay or hospital length of stay. Another secondary outcome that they mentioned was time on mechanical ventilation, which was also the same as well. So after tracheostomy is completed, there are some complications for tracheostomy. There's immediate, early, and late. We define immediate as bleeding, loss of airway, death. You can see some of these are overlapping. Bleeding also occurs in the early stages of tracheostomy. More common seen is around trachea or from the inside the trachea or on the trachea site. Tube dislodgement is another big one. Scary sometimes since it's a fresh new trach. RTs usually don't want to manipulate any new trachs since they do have a fear of losing it and not being able to establish an airway after that. Some of the long-term complications that we see at our institution is tracheoesophageal fistula. It's one of the bigger ones. Tracheal stenosis is also another one. I haven't personally seen granulation tissue or as much as the other ones. So one of the big questions is how does the tracheostomy performed? There's 2 different ways that it's currently performed. It is surgical type, or there's what we call a percutaneous dilation technique. Surgical is done in the OR, obviously more invasive than a percutaneous technique. Needs a more controlled environment. The percutaneous dilation technique actually uses a series of dilators to expand the trachea and then insert the actual trachea. One of the best things about PDT is that it can be performed at bedside, and it's usually done using a bronchoscopy procedure as well. So you can see on the picture that the bronchoscope is introduced in the endotracheal tube, and the incisions are made below the bronchoscope so we can visualize where the trachea can be inserted. So some of the advantages, disadvantages of surgical versus percutaneous is most physicians actually prefer the percutaneous over the surgical. As I said, surgical can be more expensive since it has to be done in the OR. Requires more staff. It's a more invasive procedure, so a little more risk involved. In order to do a percutaneous, though, there are several criteria that must be met first. Patients are able to hyperextend their neck, their tolerance to transient hypocarbia and hypoxemia. There also needs to be a presence of at least 1 centimeter distance between the inferior cricoid cartilage and the suprasternal notch, ensuring that the patient will be able to be reintubated just in case an axial extubation does occur. So some of the relative contraindications to percutaneous, to do a percutaneous would be if a patient needs an emergency airway. So in a trauma case where you don't have a way to get an emergency airway, a percutaneous technique would not be something that you should be doing. If a patient has a difficult airway, obese patients that have clotting disorders, or just have an increased bleeding risk from decreased platelet count. Some of the advantages that I mentioned of PTD are that it is way less expensive than a surgical procedure. One of the biggest advantages of percutaneous technique is that it can be performed bedside in an ICU. We do here at bedside very frequently. A lot of our RTs are involved in assisting those, so it's a lot fewer complications from that. So once the procedure is performed, what type of tracheostomy tubes are there? So initially there were metal tracheostomy tubes, if you guys remember, not frequently used anymore. They were usually made of silver or stainless steel. Currently we have tracheostomy tubes that are made of PVC, silicone, or even polyurethane. There's different features for each material that's used. PVC softens at body temperature. Silicone is naturally soft and affected by temperature and resists colonization and biofilm buildup. There's different types of tracheostomy tubes available. Each one is picked based on what the patient's needs are. Tubes can be angled or curved. You can see in the picture there based on the patient's anatomy. You may want to pick angled or curved based on that. Tubes can be extra length and proximal or extra length and distal. Extra length proximal just means the patient has a larger neck, and extra length distal means that the patient has a longer trachea. Some of the tubes available are also adjustable flanges, so you can adjust the flanges of the trachea itself. Tubes can also be single cannula or dual cannula. There's also disposable inner cannulas or reusable inner cannulas, which helps decrease biofilm, as I read in one study. Tubes can also be fenestrated. So fenestrated tubes are used for weaning, have an opening above the cuff. So cuff must be deflated in order when the patient is not on a ventilator. Caution should be used when using fenestrated tubes. Since these are open, it can cause trauma when trying to suction. The suction catheter can go through the opening of the fenestration. Tubes can also be cuffed or uncuffed under their used for weaning for patients. So cuffed tubes are usually used for patients that needs to be on a ventilator, and uncuffed that are usually placed on patients that are for short term for airways. Tubes can have a subglottic suction port. These are really nice. You attach it to a suction. It helps clear secretions above the cuff. Tubes can also have a foam cuff. These are nice to use with patients with airway pathology issues. So with all these tracheostomies, what trach do we select? Selecting the appropriate tracheostomy tube. So as I mentioned, is some of the things to consider are oxygenation and ventilation requirements, anatomy and airway pathology, long-term or short-term use. Is a patient going to be requiring an airway just until the procedure is done, or is a patient have a neurological injury and they're going to require a long-term tracheostomy? Here's a quick picture of an anatomy of a tracheostomy tube. You can see these parts of a tracheostomy are pretty similar throughout all trachs, and things can differ based on different tracheostomy tubes. Obturator is one that is available in every tracheostomy. There's a picture of an inner cannula there. As I mentioned, that may be optional. Some tubes are single cannula, some are double cannula. A pilot balloon will be available for a cuffed tracheostomy tube, and the plug may be available with tracheostomy tubes as well. So selecting the appropriate tracheostomy tube. So selecting the right size. All the tracheostomy sites are sized based on their inner diameter. Actual size can vary depending whether there's an inner cannula present or not. Sometimes it does create confusion and potentially hazardous when changing tracheostomy tubes because size is based on inner cannulas, inner diameter size. So size 6 tracheostomy tube can have a different outer diameter as well. Here's a look at a little graph that I found. A study done by Dean Hess shows different size inner diameter tubes have different outer diameter size and also have different lengths. So you can see a Portex disposable inner cannula size 6 has an outer diameter of 8.2 and has a length of 64 centimeters. Shiley size 6 inner diameter has an outside diameter of 8.3 and a length of 67. And a Bavona air cuff has ID size 6 has outer diameter of 8.8 and a length of 67. So you can see this can create some confusion when trying to select a tracheostomy since there are so many different kinds. So how do you manage a patient on tracheostomy? There's equipment that's needed at bedside there's usually similar in all institutions. Some of the important things that we need at bedside when a patient is trached is a suction canister and correct suction catheters. Spare tracheostomy tubes, you want to have one size the same and one size smaller. This is so if we're not able to put the same size trach back in, we'll try to put a smaller size back in the patient. Operator will help insert the tracheostomy tube. Resuscitation mask, a bag with mask. Humidification setup and oxygen setup. A side note on the resuscitation bag, remember tracheostomy and laryngectomy are two different things, so we don't want to bag a patient that has a laryngectomy. On tracheostomy, you can bag the upper airway is connected to the lower airway. On a tracheostomy and a laryngectomy, it is not connected. So just a side note on that. So managing a patient immediately post-op is very important. Significance of tube dislodgement is greatest immediately post-op. Tubes are usually secured, either trach ties or they are secured using sutures. They say that a tracheostomy site takes about 4 days for a stoma to become established if it's surgically done, and about 10 to 14 days if it's done through a percutaneous procedure. Suture should be removed as soon as possible, as this can cause some pressure sores and whatnot. Trach change should be done once the stoma is established, and it is recommended that it's done every 30 days. Actually, the evidence on this is not very solid on it, so most of these are recommendations made by the head and neck surgery based on experienced clinicians. If a patient does have a tracheostomy tube with a cuff, it's important to manage the cuff pressures at appropriate levels. The recommended pressures are 20 to 25 centimeters of water. If a patient does require higher cuff pressures, may need to reassess that the trach selected for the patient may not be appropriate. Maybe XLT is needed for the patient, or maybe a patient needs an XLT distal. Cuff pressure should be kept deflated unless mechanical ventilation is needed, or cuff is inflated to prevent gross aspiration. Another important key aspect is humidification. There's different types of humidity you can provide to patients. There's cool humidity, heated humidity, and you can also provide HME. Cool humidity is for patients that have minimal secretions. Heated humidity we provide for patients that usually have thick secretions that are tenacious. It's hard to break up. And HME is usually used for patients that are obviously with secretions that are under control and that are not requiring oxygen as well. Suctioning a patient with a tracheostomy, you should use a suction catheter that is no more than half the inner diameter of the tracheostomy tube. You don't want to occlude the entire tracheostomy tube and cause distress to the patient. Suctioning pressure should be appropriate. It should be about negative 100 to negative 150 millimeters of mercury. And suctioning should be done, as I mentioned before, should be done with care when doing suctioning with fenestrated tubes. Swallowing is another aspect of patients when managing a patient with tracheostomy tube. Important to have speech therapy evaluated the patient. Cuffs should be deflated when the patients are eating. It is recommended. If a cuff is inflated, monitor signs of distress. Cuff inflation may cause mechanical dysphagia. If the cuff is inflated too much, it can push up on the esophagus and prevent patients from swallowing. One of the key important reasons we said tracheostomy is it's better than an intratracheal tube is patients' ability to communicate. This can be achieved for patients that are spontaneously breathing and on a ventilator. Patients should be evaluated by all therapists, including respiratory, speech, and language. There are several different products available to attain communication, where we can put them in line or we can put them on a non-ventilated patient. One of the easiest and oldest ways to have patients communicate is to place a finger over the opening of the trachea so air can pass the vocal cords. It's also called a digital occlusion hub. Patients who are unable to perform the overall task, there are speaking valves that were created. The most commonly ones that we know is the passive mirror valve. It's important to ensure that there's no contraindications when speaking, when using the speaking valve. For instance, cuff is inflated or there's an upper airway obstruction. We can't use speaking valves in those situations. So as I said, there's passive mirror valves available, and if oxygen is needed, some of the valves do have the ability to place oxygen in line. Also, we can also place a patient on a tracheostomy on a trach collar to provide some oxygen as well on top of the passive mirror valve. Passive mirror valve also can be used in line with the ventilator. These can be used so that patients are able to talk while they're on a ventilator. Just remember that the voice is going to be lower since the amount of air that's expelled through the low cord is not as much as when the patient's off the ventilator. Can also be used with fenestrated tubes. Remember, one of the big things to remember is the cuff has to be deflated. Some of the tubes, trach fenestrated tubes, have flaps that open and close, so that's nice if you're going to use it in line as well with the ventilator. Managing a patient, tracheostomy patient at home is not much different than managing the patient in the hospital. They do require the same equipment, same competency. So it's important to identify who are the primary caretakers of the patient and how much support is needed. Some may require basic trach management. As a trach hospital, can the patient self-care? Do they need complete assistance, maybe from a family member, or maybe they need a full-time nurse or a respiratory therapist to take care? Education and competency must be performed on patients, on caregivers, who's going to perform the basic management to ensure that they are able to do this at home, and they can demonstrate that they're able to handle any emergencies that do occur at home. Some of the equipment that's usually needed at home is suction equipment. Some patients may need a ventilator, so may want to have education done on the ventilator as well. This is a flowchart that was created by the UK National Tracheostomy Safety Project for emergencies for tracheostomies. It's available online. It's pretty in-depth. It talks about who to call, talks about what to do in emergencies when the tracheostomy is removed, talks about what to do if a patient's suctioning issues. Can you not pass a catheter through? So it's pretty in-depth. It was created, and it's pretty nice. Weaning from a tracheostomy. Tracheostomy should be removed just like an ET tube as soon as it's not required. Several institutions looked at several criteria before considering decannulation. Some of the things to consider that are recommended is the patient have a patent upper airway? Can the patient maintain and protect the airway spontaneously? Does the patient not require mechanical ventilation support anymore? Is the patient hemodynamically stable? And is there any signs of infections for the patient? So there's lack of evidence to support when the patient is to be ready to be decannulated. As I said, it varies from institution to institution. Some institutions have protocols in place to determine when the patient is ready to be decannulated. Some of the most commonly weaning practices that we know of are, we do speaking valve trials, we do capping trials, we downsize the patient's tracheostomy, we change the tracheostomies from face fenestrated or to cuffless tubes. So there's some of the things to consider when doing weaning from a tracheostomy. I hand it over to Julia now, who should discuss pediatric tracheostomy.
Hey everyone, and thank you, Ankeet, for that discussion about adult tracheostomies, but just a great overview of tracheostomies in general. I'm going to talk a little bit about some pediatric specific things with tracheostomies, as well as some pediatric-specific complications that we might face. So basically, the history of a tracheostomy dates back to the early 3600 BC, and it was documented in Egyptian time. Antonio Basalva was an Italian physician who performed the first documented case of a successful tracheotomy in 1954 for a patient who suffered from a large laryngeal abscess. And then the first pediatric tracheostomy was in 1976 for a patient who was suffocating from a throat inflammation. So the indications for pediatric tracheostomies can be the same indications as adults, as an adult might have for the need for a tracheostomy. Upper airway obstruction or reconstructive surgery could be a cause of a need for tracheostomies. Prolonged mechanical ventilation. Sometimes these pediatric patients are born at 26, 28 weekers. And previously, or years ago, these 26 or 28 weekers would never make it out of the hospital. But now by traching them and giving them a tracheostomy early, we can help their development and their growth. Sometimes with secretions and soft tissue control. And then also for sleep apnea. Again, those are some indications for a pediatric tracheostomy. I guess there's is there a problem with people hearing me? Am I louder now? Can anyone hear me? I'm going to keep going. If you can hear me. Okay, I guess that's better. Thank you, Shauna. Again, more indications for pediatric tracheostomies. Facial infections, any craniofacial surgeries, airway stenosis, sometimes masses that are pushing against the airway. We want to place a tracheostomy, and then any laryngeal trauma can be indications for a tracheostomy in a pediatric patient. Some of the challenges that we face with pediatric patients, I'm sure all of you guys have had the pediatric patient that comes in with a tracheostomy and everyone's kind of afraid and not knowing what to do. So let's talk about some of those challenges. So Ankeet talked about it in the first part of the slide with adults. Well, we have some of the same challenges with pediatric patients. Selecting what size trach tube to use is a huge thing for pediatric patients. We either can use, there's this kind of decision about whether or not you're going to need a cuffed versus an uncuffed tube. And we kind of go between using a Shiley tube, cuffed or uncuffed. But if we do have to put in a cuffed tube because they're requiring such high pressures on the ventilators, and we need that cuff in order to ventilate them, which is a lot of pediatric patients, then we typically go with a Bavona, the Bavona tight to shaft cuff trach tube. This then becomes where the cuff becomes part of the cannula, and this makes it easier for insertion and changing the trach out for when these patients go home. We try to prepare ahead of time so that because when the hole is so small in the neck, the families struggle with getting that tube back in. This way, the Bavona, because the cuff becomes part of the tracheostomy or part of the trach tube, it's easier to insert, and then you still have the full benefits of the cuff. There are some contraindications for use with the Bavona. Used to be that with Bavona cuffed tubes, we would always change them out because they were not MRI compatible, although sometimes now the Bavona cuffs are made where they are MR compatible. So you just want to check and make sure that they are MR compatible before going into the scanner. The selection size is it's one of the considerations that you have to take into consideration with pediatric trach tubes. And you really have to look at the underlying etiology or what you're giving the patient a trach for. If they're having a trach because they are having consistent aspiration, you may need a larger diameter of a trach. Versus you may not need a cuff if they're having aspiration, and then you may need a larger diameter and a cuff with aspiration. If really they just need it for nighttime ventilation for sleep apnea or CCHS, then you can use a smaller tube. And then if they're going to require long-term mechanical ventilation, that also has to be taken into consideration when selecting the appropriate size of trach tube. Some of our pediatric patients, they will have the need for a custom tracheostomy tube, and some of these indications for a custom tube are tracheal stenosis. These custom tubes can provide an easy insertion, and sometimes these babies just have really, really big heads, and they don't have any neck, and so you really just need the tube to come out a little bit further from their neck so that so that you can have better access to the tube, because their neck will occlude the trachea if it's not, or their chin will occlude the trachea if it's not coming out a little bit further. And you can see in the slides some of the custom-sized tracheostomy tubes. One thing to consider, I did want to mention with this on the custom trachs, one thing to consider is that this, with it protruding further out of the neck, it then can be something that the patient grabs a hold of and pulls on. And as you guys probably know with pediatric patients, anything that they can grab a hold of and pull on can often be a challenge. So we have to kind of weigh the pros and the cons of, do they need a larger customized tube to have better access, but then if they pull it out and decannulate themselves, then it's probably not the best idea. Attachments can also be a challenge in pediatric patients. HMEs are used in pediatric patients, but they're not the first choice for humidification because the tubes are so much smaller and the inner diameter of the tubes are so much smaller. They do have they do tend to get occluded easier and have obstructions easier. So we typically try to at least have patients sleeping on heated trach collars, and then only do HMEs for a little bit of time during the day, so that those secretions can stay moist and they can easily mobilize them. Also, the passing mirror valves can also be a challenge. some of the times patients need higher ventilatory support that a passing mirror valve can support. So we have to kind of, again, weigh the risk and the benefits of passing mirror valves. Suctioning. For suctioning, patients with pediatric patients with a tracheostomy can often be difficult. Pediatric patients are, because their airways are so much smaller, we have to have pre-measured suction depth for pediatric patients. You do obviously want to suction pediatric tracheostomies. You want to maintain and keep the airway patent. And by doing that, you want to make sure that you have all of your suction equipment ready at the bedside. But we do have a calculation for a pre-measured suction depth. And so all pediatric tracheostomies have kind of a pre-measured suction depth that you don't want to go below, because you don't want to cause trauma, and you don't want to cause the patient to brady and have a desaturation spell because you went too low. So here's kind of the formula. You have the length here, the tube length on the box. Add 3 centimeters, and so 7.1 or 7 would be your suction depth for your pediatric tracheostomy tube. Emergency equipment at the bedside. This is a huge thing that we try to teach our families, as well as we teach our new learners that come in, that the best thing to do when you first are taking care of a patient at the bedside is that you want to make sure you have all of your emergency equipment ready, and that is your ambu bag, and you really want your mask. And I hear, a lot of times I hear new learners saying, well, why do I want a mask if I have a trach? Well, you always want to be prepared for the worst, right? What if that trach comes out? And you also want to have it connected to your oxygen supply. You also want to have your suction set up, as well as your suction catheter size that can fit down the tracheostomy tube. You want to have a size tracheostomy tube that the patient has in, as well as a size smaller at the bedside. And then your pulse oximeter and your extra lubrication and your extra trach ties. And then what happens if the trach comes out? So immediately you want to call for help. Begin to bag mask ventilate your patient. And then if you can't bag mask ventilate your patient because the trach tube is out, then you either need to put another one back in, or if you can't get another one back in, occlude the hole and then bag mask from the mouth or from above. So one of the things that we always want to make sure that we have, and we have these charts kind of at the bedside, is that if there happens to be an accidental decannulation, the best thing to do is always have a plan. So we always want to have a plan, and then we follow these steps. Hyperextend the neck, and then we want to reinsert the tube immediately. We want to reinsert it if possible with the same size. If you can't with the same size, then you can go down a smaller size. If you're unable to insert the smaller size, you want to make sure that you notify our ENT specialist, hyperoxygenate the patient, and then assess respiratory status immediately. Also, one of the things that is the best way to prevent accidental decannulations is to have your trach tie secured with one finger, and that's an excellent thing to check at every assessment of your patient. Make sure the trach ties are checked with one finger. And since we were talking about trach ties, this is something we see often from a caregiver's point of view, as well as a home care provider, is that when do you change the trach ties around the patient's neck? So again, this should be done as a 2-person procedure, and because we're dealing with pediatric patients, it's often difficult to change the trach ties and keep the trach in place. That's why you want to have 2 people. You want to have one person that's always got their hand on the trach, because these little babies like to do barrel rolls in the bed, and trying to keep them down while you only have one person changing the trach ties can be very difficult. So always having 2 people to change the trach ties is very important. You want to have your trach ties prepared ahead of time so that it's a lot easier to just slip them in and take the old one out and put the new one back in. And then really check to make sure you have that one finger that the trach tie is tight enough for that one finger. Then you want to insert your slit gauze underneath the trach, and if adjust it if it's too loose or too tight. Like Ankeet said, you can get granulation tissue at the trach site, so it's important to look for that every time you change the trach ties and gauze.
So a multidisciplinary approach, we talked about all these things that we're going to be doing, including changing trach ties, changing trachs, downsizing, changing it to a fenestrated. So who does all this? Who's in charge of all this? Some institutions have implemented multidisciplinary tracheostomy teams. I know Julia has one at her institution. Here at Rush, we're actually working on to create a multidisciplinary approach to managing tracheostomies. So some of the goals from this multidisciplinary approach is to improve management of patients, obviously. So who does doing the speaking trials, valve trials, doing the cap-in trials early, getting the tracheostomy downsized early. Some of the members that are the team include respiratory therapists, speech language pathologists, a clinical nurse specialist, or a physician. These usually show that several studies have shown that it decreases ICU stay and increases in speaking valve use. Just weaning the patient off the ventilator faster using a multidisciplinary approach. Some of the challenges in tracheostomy. There was a study done by the UK National Confidential Inquiry into the Patient Outcomes. They looked at, outlined several risks for morbidity and mortality with management of patients with tracheostomy. They discussed several case studies for each topic and give recommendations based on each topic. So, for example, if a patient's trach got dislodged, what would you do in that case? And there's several recommendations they make based on these events that occurred.
And a few of the best practices that we've learned in taking care of tracheostomy patients is that it's really important to have a multidisciplinary team and to have this multidisciplinary team rounding very early on in the patient's care, from the time the decision to trach the patient is made throughout the course of their stay in the acute care phase. So transitioning these patients to home is solely dependent on caregiver education. So multidisciplinary rounding can help identify these needs early on. Care coordination is a huge barrier in these trach patients, and they're often lost to follow-up. So having someone to kind of walk these families through what they're going to be expected to do at home, helping them navigate the system, set up these follow-up appointments, set up appointments with speech pathology. If the patient's requiring too high of ventilatory support, maybe there are special programs on iPads that the speech and language pathologist can work with to help these patients have a voice. Setting up appointments with pulmonary clinic, complex care clinic, or a medical home, and then ENT. All of these services individually are difficult to navigate through. And then if you think of a patient who has a tracheostomy and now has to get clearance from, maybe needs to have a bronchoscopy done from a ENT point of view as well as a pulmonary point of view, because we're looking at lung disease as well as airway granuloma tissues, that kind of thing. Can they be downsized? All of those things are very difficult to coordinate on their own. And so really having someone help with that coordination of care it benefits these patients in the long run. And then education for families and caregivers should really start at the bedside. We tend to do education on the actual surgical procedure. This is what's going to happen in the surgical procedure, but sometimes that's as far as it goes. So these families aren't informed about how what they're going to have to do to take care of their patient at home once we've given them a tracheostomy. What are the things they're going to have to do? How in depth are there whenever you're in home? How in depth is the care when you take these babies home with you, or these adult patients home with you? So talking about a caregiver checklist, I have an example, and this is one of the things that we do at our institution. And in our special care unit, the families have to go through a series of checklists. Then they have to perform certain actions before they can go home. The nurse and the respiratory therapist at the bedside work with these families on changing out a trach at least once before they go home, suctioning independently. Are they able to bag? These patients effectively? And so these are the number of checklists that they have to go through. And then there's also a step further, and patients that are high risk that are going home with tracheostomies, like I said before, 10 or 15 years ago, these patients may not have ever left the hospital. And so we have to now expect parents to take care of these very medically complex children at home with very little skills, if you will. So what we've developed here at our hospital is simulation-based training for families. And so we bring these families over to our simulation center, and we put them in these stressful situations, these accidental decannulations, plugging of the plugging of the tracheostomy tube. What happens if alarms are going off? What to do? And we walk these patients through this simulation-based training to really prepare them for this home environment. And there's a series of checklists that these families have to go through in the simulation, in the environment before they're ready to go home. There's often questions that say, well, what if the families don't do well? What if they don't pass? Their checkoff? Well, we have oftentimes had to bring families back that maybe are not prepared, or they don't realize the intent of taking care of their baby with nobody else in the room, in the environment. So that's often a challenge.
So as Julia mentioned, there's challenges faced by everybody. Challenges faced by respiratory. Some of the challenges that we face as respiratory therapists is not knowing who the care team to contact is. At least inpatient is one of the biggest issues. Is once a trach is performed by ENT or surgery, who's taking care of that patient? Who's going to be doing the first trach change? Who's going to be doing the removal of the sutures? So these are some of the things that a multidisciplinary team can help to resolve. No formal institutional protocol is, having an institution protocol helps manage a patient a lot quicker, gets them the education they need, like Julia said, gets them the equipment they need a lot quicker, gets them moving faster, in and out of the ICUs faster. There's lack of communication between the different services, post-procedure management. So, there's no multidisciplinary team. There's no communication. That's usually what we see in the hospital. That a lot of the things break down is when communication stops. With the ENT performing the surgery, but they don't communicate back to the primary team. They don't communicate back to the respiratory therapist, to the speech-language pathologist. It's kind of a chain of effect that communication is one of the biggest keys. And a lack of advanced education for respiratory therapists. RTs receive basic education in school. Sometimes RTs work in a hospital environment in a small community center where they don't see those tracheostomies. They don't see bedside tracheostomy performed. They don't see the different types of tracheostomies that are available. Just seeing different types of tracheostomies is kind of helpful because you get to deal with those patients and understand how those tracheostomies work. Having the tracheostomies that are filled with air, that are filled with either water, different types of tracheostomies that you can observe. As Julia said, one of the biggest things is education. Providing education at their institution. They provide simulation-based education. Having the proper checklist before they go home. Currently at Rush we didn't have one. We just recently had a peds patient get transferred home with a trach first time. So we had to create a checklist and then go through the education with the family and have them checked off and make sure they're comfortable doing these proper things. So these are some of the challenges faced by by caregivers and patients. Having the proper equipment available. Can the home DME provide the proper suction equipment? Can they provide humidification equipment? Do they have the appropriate need for the emergency supplies? So these are some of the things that we have to take on as a group, as a respiratory therapist, and just keep fighting to get involved in tracheostomy care more. Here at Rush, we're trying to get involved a lot more by creating this tracheostomy multidisciplinary team, trying to be involved in downsizing trachs, trying to be involved in taking action to getting patients off the ventilator faster, using speaking valves on mechanical ventilators. Some of the things that we try to do here at Rush, I'm sure other RTs are trying to do similar things, trying to get involved in tracheostomies. Julia, do you have any closing statements?
I think that pretty much sums it up, Ankeet. I know we have some questions, and I think Shauna was going to help facilitate some of the questions.
We have some fantastic questions. Thank you so much. Listening to this presentation brought me back to my own experiences with tracheostomy tubes, and these questions that are coming in from the audience are fantastic. So we're just going to jump right on in. One of our attendees wants to know how patient education is completed in your institutions. Is it in the patient's room? Do you do it in a group? And do you include simulations in that training?
Julia, you want to go first?
Sure, I'll go ahead and answer that. So all of the above. We don't do a whole lot of education in groups anywhere in the hospital because of HIPAA, and there are very specific needs that a lot of these families have with tracheostomies. So families are given one-on-one training in their room over several weeks with a bedside nurse, with the bedside respiratory therapist, as well as a dedicated trach educator. And then, like I said, they have a series of checklists that they have to do in order to be completely checked off. And then we do simulation-based training, and that's outside of the room. We really want to get the families away from that environment so that we can focus on really, do you know the skills that are required to take care of patients in an emergency, or to take care of your baby in an emergency. I hope that answered the question.
I think as Julia said that, the education, they have great education, sounds like there. We currently don't have that platform here at Rush, but we're working on that. So I think every institution is going to have different form of education. We actually just had a patient we were talking about with my educator that they come into their physician's office every 30 days to get their trach changed. But it sounds, it's a trach change that a trach that's been established for over a year now, shouldn't have to come in the office. You should have the caregiver at home be able to provide that service for the family member, that they should be able to change the trach out quickly at home. So we were going to do some education one-on-one, but we don't have any competencies laid out for the adult side at least, so we're kind of still working in that progress. So I think different institutions have different where they are in their trach education and trach management at least.
Thank you both. I think that there are a lot of ways that facilities can improve or work together to make that discharge planning a little more seamless and prepare those patients. So speaking of preparing the families and the patients to go home and hopefully discharging to home, when do you recommend involving the home care provider?
I think once they get that equipment education, it should be right away. I feel like, once they go home, they have the equipment available. The DME should go there and have, that follow-up education, make sure they're able to work with if there is any new equipment that's provided that's different from the hospital, so they can fill in those gaps. They'll at least have that background knowledge of what suctioning requirements are, what the suctioning pressure should be, the suction catheter, how big they should be, things like that. They should have background knowledge. But if there's new equipment, they can fill them in. So I think it should be right away, right as they get home from the hospital, I feel.
So we have a very kind of interesting and difficult situation with home care companies in Texas, and I'm not sure if that's everywhere, but our DME companies won't really get involved unless the patient is 30 days out from going home. And so we keep some of our patients stay in the hospital for a very long period of time, while they're getting all this education, while they're growing, while they're doing procedures, or maybe they're just medically not stable to go home. And I know for sure with our ventilators, home care companies will not deliver home care ventilators unless they're 30 days out because they don't get reimbursed. If they're in the hospital, they don't get reimbursed for a home care ventilator. So they tend to tell us that unless they're about 30 days from going home, not to involve them in these in their care. So it's often difficult because we're trying to transition these patients to home ventilators, and it may take some time to transition these patients over to a home ventilator. And so we would like to get them in very early on, as soon as we make the decision to trach them and we know they're going to go home. But we struggle with getting a ventilator in the hospital that they're going to go home on. So what our hospital has done is we've purchased a few of the home care ventilators that they're going to go home on, and we'll let the patient trial the ventilators on our ventilators until they get to a stable point where we can get the home care facilities to bring in the equipment. And then pediatrics is also very difficult because a lot of the home care companies look to us for training for pediatric patients because they don't see a ton of them.
Fantastic. And I'm just going to go right to the next question because we have some phenomenal ones. So one of our attendees is a college instructor, and she has noticed that the clinical sites are not using heated humidity on patients who have tracheostomy tubes, but yet the patient may be on other interventions for secretions, although she and I need to talk about this whole mucomist thing. We need to get rid of that. So any comments on the sites not using heated humidity, but using other interventions because of those thickened secretions?
I'm not a big fan of mucomist, just like you're not. So our first go-to is heated humidity. Actually, there's no data evidence currently for optimal humidity for trach patients. We at Rush are doing a research project to two different types of humidity for patients. So we're doing our basic trach collar setup compared to and then we're comparing it to a patient that's on what we high humidity, high flow device that provides them constant humidity and a constant temperature. So results pending for at least optimal humidity for a patient. But I feel heated humidity is preferred compared to other interventions such as mucomist or sodium chloride. Me personally, in my personal experience, I've had great results with heated humidity.
Our policy says anyone admitted to the hospital on a tracheostomy goes on a heated trach collar. That's our facility's policy. So those are my thoughts about it.
So bouncing off of the heated humidity, another attendee had recognized that one of the slides mentioned cool aerosol with minimal secretions, but with the heating and the humidification of the upper airway bypass, this person thought it would be less effective for airway conditioning. So what about the cool versus heated?
So our facility, our general practice is for trach patients to go on cool aerosol initially, unless indicated for heated humidity. So our general practice is to put them on cool aerosol just to provide some humidity and provide oxygen if needed. And if we start noticing secretions are getting more tenacious, then we transition to heated humidity. And then if needed, we may add on other interventions such as sodium chloride to help mobilize secretions.
I think our institution does not use any cool humidity for trach patients.
So with regard, I'm sorry, go ahead, Ankeet.
No, I just hope that answered the question.
So I'm going to turn this question over to Julia because you were talking about the Bavona trachs and making sure they were MR compatible. This attendee hadn't heard that before, so asks, what makes the Bavona trach not MR compatible?
So there used to be a little, in the foam of the Bavona trach tubes, there used to be a coil that would make them not MRI compatible. So now that the tight to shaft are water cuff tubes, they're able to go into the MRI.
So the point of the exercise is to make sure that the patient has a cuff that does not contain that little metal piece.
Correct. Yeah, and it says it actually on the flange of the trach if it's MRI compatible.
Oh, well, even better. So, Ankeet, we have a question from the adult side. How do you deal with patients who receive a trach and then the physician wants to discharge them the next day? Wow. That might be
we haven't had any of those
than basic education.
Yeah, that's, that must have had some pre-planning done pre-op, I'm guessing. We haven't had any of those, so I really don't know how to deal with that patient or the education that go along with it. I'm sure the physician must have had quite a conversation with the patient that you're going to go home and get a trach and go home the next day. Yeah, I'm sorry, I don't know how that's dealt with at least our institution. We haven't had any patients go home right at the second day after they got a trach.
So let's go back to the patient education piece. What do you do when the caregivers have failed the education and haven't demonstrated competency, but the patient is scheduled for discharge?
I can answer that question.
Yeah.
Okay. So our patients are never scheduled for discharge until the families have met their criteria to go home. We work with the families as much as we possibly can. If we have a caregiver who's just not getting it, we ask for a secondary caregiver. We don't often find families that just don't get it. We bring them back repeatedly until they do get it. What we struggle with more is we find families who don't want to do it. They don't show up for their training. They don't want the trach, the patient to go home on a trach, and so they're refusing to learn anything about the trach. They're refusing to learn anything about how to care for their babies at home, and so when that's the case, we do several opportunities, several interventions, and then we start to get the Child Protection Services in and say, this is, in order to go home with your baby, you have to be able to pass these things and do these procedures.
We currently don't have any education plans, so it's Julia will be kind of like your expert on this, at least some background on that.
Well, Julia and Ankeet, I wish we had another hour to talk about this, but unfortunately we're out of time. Thank you both for joining us.
Thank you, Shauna.
Absolutely.
Thank you for the opportunity.
And thanks to everybody on the line who joined us. I hope you enjoyed this as much as I did. Please join us for the next Respiratory Care Journal Cast on Thursday, December 21, with the December Editor's Choice presented by Ms. Julie Jackson. And the AARC kicks off the 2018 series on Friday, January 19th, with the January Respiratory Care Editor's Choice presented by Mr. Tom Perino. Again, thank you for joining us, and have a great day.
Excellent. I think that's all the time we have for today. Thank you to our speakers for sharing their expertise, and thanks to our participants for joining. In just a moment, you'll see a Submit Credit button appear on your screen. If you're an individual who's registered for this program, you will go through the credit submission process on your individual account. Should this button not appear, please navigate to the Credit tab and select the Click Here button linked. If you are a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This concludes today's program. To simply exit out of the browser window to end this event. We hope you have a great afternoon.